Okay, thank you for joining us this morning. We're going to talk about digital chest tomosynthesis. And I just want to say that I'm very excited to talk about this topic. Chest tomosynthesis is something that we do clinically, something I do research on. It's a modality that I'm very excited about, and I'm very happy to have the opportunity to help other people learn a little bit about it, become more comfortable with it, and maybe find a way to use it and help it fit in a way that really helps patients and helps us with our mission of taking care of people. So as a quick introduction to who I am, my name is Gregory Kicska. I'm an MD PhD, and I practice here at the University of Washington. I'm an associate professor in the Department of Radiology. I'm in the thoracic imaging section as well as the cardiovascular imaging section, and in the thoracic imaging section is where we do tomosynthesis. I've done a lot of research throughout the years. One of my areas of interest is actually in tomosynthesis, particularly related to simulated tomosynthesis. Okay, so tomosynthesis. Tomosynthesis is something that many people have heard of in the past, but they may not be familiar with digital tomosynthesis. If you remember from linear tomography, this was something that used film, and of course this is a new iteration of that type of modality, and we'll talk about that in more detail. So as a quick overview, I'm going to first discuss tomosynthesis as a technique, and that is going to be things like, how is the equipment used, how does it make the images, and how does it technically compare to CT and radiography in terms of how it generates the pixels that we see on the screen. Then I'm going to discuss the clinical applications, and that would be things like, is there any evidence out there that tells us how this modality performs? Maybe are there specific indications that have been investigated? And then I'm going to discuss practical implementations, sort of my personal view of how this could fit into your general workflow, and also what does some of the evidence suggest is a good way to make it fit into your workflow. And I'm also going to talk about what I think are maybe some barriers to implementing it, and things that I've just seen from my own experience with people accepting that modality here. Okay, so let's go ahead and get started. And as I said before, a lot of people have heard of tomosynthesis, but you may actually be thinking of old linear tomography. This was a modality where you had an X-ray source and a detector plate, and they basically went past each other and generated one single slice per sweep. And that's not what we're dealing with here. We're dealing with a modality that, yes, does make multiple slices, but it does it from just one image acquisition. Okay, so you have a modality, tomosynthesis, which uses essentially the same equipment that chest radiography uses, but it produces slices like CT. So I think of chest tomosynthesis as a fusion between chest radiography and CT, although there are some unique advantages to chest tomosynthesis that we'll talk about. Okay. Throughout this talk, I will be abbreviating occasionally digital chest tomosynthesis as DTS, and that's commonly how it's abbreviated. And chest radiography, I'll be abbreviating as CXR. Okay, so how does chest tomosynthesis work physically? Let's start by just looking at a radiograph, because I said it is a fusion between these modalities. So in standard radiography, you have a detector plate, person standing in front of it, and a single X-ray source. The X-ray source projects through the patient, and you get this image that you see on the right of your screen, the chest radiograph. That is basically a ray sum of all the paths through the patient's body. At any point there, you see it's basically one slice for the entire body, and that's chest radiography. Right? In CT, you have a single source again and a single detector, but these things will orbit around the patient, obtaining multiple projections, and it's this information that we use to create those cross-sectional images, because we go all the way around the patient, or 180 plus the fan beam angle. Compare this to tomosynthesis. So again, I have chest radiography on the upper left, CT on the bottom left. Now let's look at tomosynthesis. You immediately can see that the setup is very similar to radiography. You have a single detector behind the patient. It is stationary. You use essentially the same source, but instead of it staying still, this source actually slides and takes multiple pictures of the patient from several angles. You're basically taking 50 to 60 chest radiographs of the patient, but at a fraction of a normal chest radiograph dose. You use all these projections similar to CT to create your cross-sectional images. This is a picture of an actual tomosynthesis instrument, and you can see it looks just like a regular chest radiograph setup. You've got the patient in front of the detector, and you can see the source over there on the right. But the source moves up and down, tilts, always pointing at the detector while it acquires all these images. They look very similar to chest radiography setup, and in fact, in many cases, it's identical. A lot of institutions have this system installed, and all that's required is a very small software upgrade to make it tomosynthesis, to make it capable of producing tomosynthesis images. And so, of course, it makes it a low-cost modality because compared to CT, because the instrumentation is much cheaper than CT. And there's a lot of flexibility in terms of the way you can position a patient there. You know, you can't have a patient stand in the CT scanner. And then you're not just confined to chest. You can actually do tomosynthesis of any body part, although I will be talking about chest applications as we go through this. So now I'm going to show you a video of an actual tomosynthesis instrument acquiring those projections, the ones that are used. Okay, so here's this video. Okay, so this patient's standing there. The machine is moving. It takes about 8 to 12 seconds, and while it's moving, it's constantly taking multiple radiographs that are getting read out from the detector. Okay, and that's it. That's all that's required to do your back projection and obtain your slices. So there's a couple advantages here. One is you are using, again, chest radiography equipment, and I did mention that that does have a advantage in terms of cost compared to CT, but you also get a resolution advantage because the detector plates in radiography are much higher resolution than they are in CT. We're going to come back to that in just a little bit more detail. But first, let me just show you our comparison between the modalities to give you a sense of what these images will look like. Okay, first we have a chest x-ray. I showed that to you before. I know that many of the people who are listening may be radiologists, but I also understand that many may not. Just a moment here. Okay. All right, so many people watching I know are radiologists, and I know many people may not be. All right, so we have a chest x-ray in the upper left-hand corner. A lot of detail there, but notice how you see the front ribs and the back ribs all in the same image. Heart, everything is there. It's as if you're looking through the person like they were an opaque piece of glass. Compare that to a CT image in the same plane, a coronal plane, and you have eliminated all of the anatomy in front of and behind the slice. All right. Now I'm going to show you a tomosynthesis image. It is somewhere in between that radiography image and the CT image. If you look, notice how you don't see all of the anatomy that you see in the upper left-hand corner. You're only seeing things that are in the slice that you're focused at. You get a stack of images, and as you scroll through the person, there is something called the plane of focus. It is like the level that you scrolled through on a CT. Anatomy in a tomosynthesis image that is in the plane of focus is sharp. As things move out, they become blurry. I'm going to show you now a video scrolling through that tomosynthesis image stack to give you a sense of what these things will look like. Oh wait, I'm sorry. We'll come back to that. Okay. Oh yes, I'm sorry. Here it is. So here we go. We're scrolling through our tomosynthesis stack. Now, these are very high resolution images. They're chest x-ray resolution, which in general are 2 to 3 megapixel images. And you have to keep in mind that your monitor is probably only, if you have a good monitor, 2 megapixel monitor, you're using in a web browser, you're seeing a fraction of the true resolution that this study has. Okay. Just a moment, let me re-push that. Okay, so again, we're scrolling through the patient. Notice how you have ribs and the anterior ribs in focus. Then they disappear. Then you see the airways. Vessels come in and out of plane as you go to the back, and then all of a sudden you see the spine. Okay, so there definitely is this this concept of you have slices where you don't have the anatomy in front of and behind, and the in-plane resolution is very, very high, which is difficult to appreciate through a medium like this. Okay, this is one last time I'm going to go through it. Okay, now, yes, this kind of looks like CT, and yes, it kind of looks like radiography, but it is a new modality for most people, and people have difficulty wrapping their heads around what they are looking at intuitively. So I'm just going to describe what determines the intensity of every pixel you see in these images so that you can understand maybe artifacts that you see or why images look the way they do, essentially to give you the tools to help interpret these studies and get started. Okay, all right, so these are the three acquisition methods that we have for radiography on the top right, CT bottom left, and tomosynthesis on the right-hand side. Let's first just look at radiography and CT. I have two images on the right-hand side there and a small red box. In a chest X-ray, so in a chest X-ray, the question is, what determines the intensity of, what determines the gray level of the pixel inside that red square that I've shown? For chest radiography, it is all the anatomy that is located inside this box, okay, all summed together. And that is the path of the X-rays as it passes through the patient that creates that pixel on the right that I indicated. For CT, it's a little bit different. Okay, so the question is, what determines the intensity of the pixel in that the pixel in that red box right there? And for that, it is the intensity of that actual piece of anatomy in the patient plus a very, very slight contribution from all surrounding anatomy. So you see how I drew this circle around the patient and I grade things out. If you took all the values in that circle and you added them together, summed them together, that would be the value of the pixel on a CT. Okay, so that's how the intensity is determined in those two modalities. Let's compare it to tomosynthesis. Okay, in tomosynthesis, remember we have a source that sweeps, okay, takes multiple images, and that determines what the pixel value is. So I drew that gray box and I drew the circle for CT and radiography on the left. For tomosynthesis, you have an area that looks like this. Again, it's funny, it's kind of an intermediate between radiography and CT. Okay, looks a little bit like a bow tie or something. If you took all the pixels, okay, so we're interested in that pixel there. If you took all the values inside this area and you summed them together, that would be the intensity of the pixel that's indicated below. So you have a very high contribution from pixels that are in plane, that are in the focus plane. But as you move from the focus plane, your contribution decreases and decreases as you move further away. Okay. All right. So when you scroll through an image, if you are looking at the same location and you're scrolling through a stack of tomosynthesis images, the thing that is actually making up those pixel values is shown on the bottom left. Okay. So you continue for each slice, you would sum together all the values and put them into the red box for that given slice. Right? That's why when you're toward the back of a patient on tomosynthesis, you see no contribution at all from the anterior chest wall, and also the reverse, and as you move through the patient. And there are certain technical factors, say for example, the angle that you decide to sweep, which will make the blurring of anatomy occur more rapidly or slower. There's another very interesting advantage here. Because every tomosynthesis slice is actually created from the superposition of multiple projections, that means to achieve diagnostic signal to noise, you only need, in total, 1 radiograph worth of dose for an entire tomosynthesis exam. For CT, because CT does not reconstruct in this way, that doesn't work. That is why the CT doses are much higher. Now, the system, there are some inefficiencies in the system, and of course there's some limitations because you lose dose as you take multiple projections. So in the end, the dose ends up being about twice that of a radiograph. But the point is that you obtain a signal to noise difference, a signal to noise ratio with a far lower dose on tomosynthesis than you do on CT. And that's why tomosynthesis is a low dose modality, relatively. Okay, compared to CT. We'll talk about it a little more in detail. Okay, there's another thing. I talked about how you get to use the chest X-ray detectors, which is fantastic because those are high resolution detectors. Chest X-ray detector has a pixel. The pixels are about 200 by 200 microns, 0.2 by 0.2 millimeters. For CT, every pixel that you look at an image is somewhere between 0.4 and 0.6 millimeters. Okay, so the resolution of tomosynthesis is automatically higher because you are using a high resolution detector. But you also have the added advantage that you are taking multiple projections from different angles, right? And that information actually creates something called super resolution, which enables your true resolution to actually exceed that of standard chest radiography by a little bit. But the point is that it is high resolution. So for every pixel that you see on a CT image, you would have 9 pixels on the tomosynthesis image, right? So to give you an example, all right, if you were going to do a CAT scan of a kitten, and which you might think is humorous, if you did a CAT scan of a kitten and you ended up with this type of resolution, but you did the same study with tomosynthesis, where every pixel you see on this image of the kitten could be broken up into 9 of varying densities, you would end up with a study of this resolution. Okay, so this CT image here has been rebinned at the same ratio. So in other words, I actually made this as corresponding resolutions of CT and tomosynthesis to give you an idea of the detail you can see. And this really comes through when you look at cases of things like fibrosis or cystic fibrosis. You know, you're looking for reticulation, like things like that. They're very, very, very crisp on tomosynthesis. Where on CT, you just end up with this ground glassy look because you're actually losing that resolution. Okay, so tomosynthesis, it has slices like CT, has resolution like radiography, it has twice the dose of radiography, and that ends up being about 1/20th the dose of a chest CT. Okay, I have a video clip again going through this, just showing you what the images produced from the modality look like. Okay, so what does the anatomy look like? It is still a new modality, and a lot of people look at it, they feel uncomfortable, a little confused, they're not sure exactly what their landmarks are. You basically, you can use your established knowledge in CT and radiography, but you still need to gain comfort. Okay, so let me just show some anatomy in tomosynthesis scans just to give you an idea of what things do look like, because maybe you've never seen this before. All right, so for bony structures, I have a slide here. On the left hand slide, I'm showing the focus plane has been set to that of the sternum, and you can see the sternum and the anterior ribs are nicely laid out. And when you think about it, when have you ever seen the anterior ribs at the positions where they're actually articulating with the sternum? I mean, you just don't see that in radiography, okay? But you can see them here plainly on the tomosynthesis image. In the center, again, I'm just showing you how if you have adjusted your plane, say, for example, that the clavicles are in focus and the anterior ribs are in focus, you don't see the spine at all. It's gone. It's been blurred away. You don't see any posterior vascular structures. If you did want to scroll back to the spine, that's what you would see on the right. And you can see a lot of detail. Tomosynthesis is great as a musculoskeletal application. These are CT overlays, thick slab CT overlays to give you a sense of the anatomy that we're actually looking at. There I'm showing you again the sternum with those the articulation of the anterior ribs. Okay, I'm showing you the spinous process on the ribs and the pedicles. Okay, let's look at some vascular and airway structures. Now I'm showing you a slice from the mid-chest. I kind of stopped it around the level of the carina. And you can see the azygos there hooking right over the top of the right bronchus and plugging into the IVC. And then I've also labeled the right interlobar artery. In terms of airways are extremely crisp because they actually happen to line right up in the coronal plane, and you can see the carina is well demonstrated. Of course, the left bronchus intermedius, the trachea is very well seen. Okay, and I'm going to go ahead and over a thick slab CT that is showing this. Okay, so that's information from a CT that I've overlaid on top of the tomosynthesis image to give you a sense of what we're looking at. Okay. Okay. Into other vascular structures, I've labeled here the right inferior pulmonary vein, the left lower lobe pulmonary artery, and I also have, you can see the main left pulmonary artery there. The descending thoracic aorta, as we scroll toward the back, you're starting to see the ribs come into view. And while we're looking at this, if you look to the periphery, it is incredible how you can see these like peripheral vessels, vessels that are just a couple hundred microns in diameter. And you actually see them quite well with the tomosynthesis. Okay, again, I'm overlying a thick slab CT to give you a sense of what this looks like. Okay, here's our descending aorta. Okay, and thick slab CT. Okay, all right, let's go ahead and let's talk about more of a comparison of the modalities. Now, I've mentioned a lot of things. I mentioned dose, equipment cost, breath hold, all of these things. Let's look at the numbers, starting with dose, because people are interested in that. For a CT, normal chest CT, generally about 3 millisieverts. For tomosynthesis, 0.1, okay? It is a fraction, 1/20th, in this case I've listed as 1/30th, okay? And I have references down here for, there have been many dose calculations for what tomosynthesis is, and they all come in that range, just like there's a little bit of variation from institution to institution. Chest X-ray is about half a tomosynthesis. Okay, so a tomosynthesis is very, very close to a chest X-ray. It's about 2 chest X-rays, PA and lateral, but it is a fraction of what you get in CT. Now, people have asked me, yes, you show these numbers, but what about submillisiever chest CT and all these other reconstruction methods and all the dose people are dropping? I understand that, but tomosynthesis still is far less in dose. And additionally, all of the iterative reconstruction algorithms that are used in CT can be applied to tomosynthesis. And I don't know when things like that will be incorporated into clinical systems, but I do know that people have used them and they exist. So that is not a hard stop for tomosynthesis. Its dose can also go down using the same dose reduction techniques that you see in CT. In terms of equipment cost, I'm not sure how much a CT scanner costs, but I think it's a lot. Tomosynthesis instruments are far less. They are slightly above a standard chest X-ray unit. When you get an upper level chest X-ray unit, you have this ability to robotically move your source. Okay, if the source is not moved with a person's hand, but can be moved with motors, in general, you have these higher end systems, and the incremental cost to upgrading that to tomosynthesis is usually a fraction of what the original cost of the chest X-ray unit was. So I consider that to be a lower cost modality. In terms of the breath hold, tomosynthesis CT is 2 to 8 seconds for chest CT. For tomosynthesis, 10 to 12 seconds. It is a little bit longer because it takes a while to read out the detector plates. However, there are manufacturers that are producing tomosynthesis instruments, not for the chest, that have much faster readout times. And they have breath holds that are going down into, say, 3 seconds. So if that is a concern, I do think that is something that you will see drop in new instruments. That being said, 10 to 12 seconds doesn't seem to be a problem something we've ever really had a problem with. Okay. Again, resolution. Tomosynthesis definitely has an edge over CT. And how long does it take to read the exams? So in one study that I've listed below, tomosynthesis took twice the amount of time to interpret as a 2-view chest, and it takes about 1/3 the amount of time to interpret as a chest CT. Okay, so tomosynthesis sounds great. I mean, it does sound great. I actually think it is wonderful. I'm not saying it's the answer to everything. Absolutely not. I'm just saying it has unique advantages, and that those can be leveraged in certain clinical scenarios where you might be able to find answers or deliver care that you wouldn't be able to with other modalities. And And I feel very strongly about that. So tomosynthesis is a lower dose. It is cheaper, higher resolution, faster, and so it sounds fantastic. And so the question is then, when should it be used? Okay, so I'm going to talk about some indications. There are varying levels. There are a lot of publications out there that have tested a lot of indications. One of the best tested indications is actually related to nodule detection. People have been very interested in looking at tomosynthesis and how well it can detect pulmonary nodules. And that's because when it comes to imaging the chest, a lot of diseases present as a nodule. The main one everyone thinks about, of course, is lung cancer as a neoplastic cause. But that could be carcinoid, metastasis, and benign things like hamartomas. You have infectious pathologies that will present as nodules. And then you have congenital pathologies, mucus plugging, vascular malformations. But the lion's share of things that people are really worried about are probably lung cancer and infections. Okay, so, well, I would say neoplasms in general, lung cancer, mets, and infection. Those are probably the three main things that when people are hunting for a nodule, that's why they're looking for it. Okay. So, lung cancer is particularly important because if lung cancer is detected early, survival is very different than if it is detected late. Lung cancer detected early has a survival greater than 50%, okay, 5-year survival. If it is detected at a late stage, it only has about a 4% 5-year survival, all comers put together. Currently, okay, if a patient is not being screened, most people show up with late stage cancer. And for that reason, you think about how every time a patient has an encounter with healthcare and they get imaging of the chest, in terms of looking for whatever the immediate clinical question is, you also want to look and make sure this person does not have an occult cancer. And if you catch it early, it can really make a difference for the patient. So I'm not talking about screening patients with tomosynthesis. I'm just saying as patients come through, tomosynthesis can detect nodules, and it's important to look for these things. All right. So people have looked at nodule detection. Let me show you what a nodule looks like as a clinical example. I have a radiograph on the left. There is a nodule in the right lower lobe that you cannot see, even with the arrow pointing at it. I'm telling you, I don't see it. In the CT on the right, it's obvious. You can see where that nodule is located. The tomosynthesis image in the center, I believe, clearly shows this nodule. Now, I think you would have to have some experience reading tomosynthesis images, but it is clearly there. There's no question of the conspicuity of that nodule. Okay, here's another case. This one's a little tougher, okay? And I picked this one because I think it kind of shows you the limit of what you can see with tomo. The last one was the limit of what you can see with radiography. Excuse me, this is the limit of what you can see with tomo. So again, radiograph on the left. The nodule's there, I cannot see it. In fact, I didn't even quite know where to put the arrow. On the right, you can clearly see the nodule. But in the middle, that nodule is there. I agree, it's difficult. That is a more difficult lesion to detect. But again, it shows you how small these nodules can get, and they are often seen in tomosynthesis. Now, people have looked at this in an evidence-based fashion. There are many, many studies of varying sizes. Some are actually quite big. I've picked some of the newer ones. This one, which was published in 2015, asked the question, does tomosynthesis detect nodules as well as chest X-ray or CT? They looked at 95 patients who all had nodules on CT. They did the tomo and the chest X-ray, and they asked people to find these nodules, and they used the chest X-ray as gold standard. The result was that tomosynthesis outperformed chest X-ray by twofold, right? However, when nodules were within 3 centimeters of the hilum, it performed at about the same level as chest X-ray. And I think that's because you really start to get a lot of dense overlapping structures in that area. But when you went to the periphery, it actually performed much better than chest X-ray. The best sensitivity was actually for nodules that were greater than 5 millimeters, and 3 centimeters from the hilum. Tomosynthesis found about a third of all the nodules that were found on CT. Okay, now there have been many other publications that have addressed this. These are just some of them. Essentially, all these publications show the same thing. If a nodule is more than 4 or 5 millimeters, tomosynthesis is very good at identifying it. All right. If a nodule is ground glass, it has a tough time. Okay, but solid nodules greater than 4 or 5 millimeters, tomosynthesis is very good. And when these nodules move to the periphery of the lung, more than 1/3, more than 3 centimeters from the hilum, it is excellent at detecting these nodules. Right? So that is a useful conclusion. Okay. Let me show you also some extra advantages. It's not just about sensitivity, right? It's about specificity. You don't want to overcall things. Okay. So this is a case where the radiograph shows something that looks like a nodule. Right? Now, granted, you would see this. You see it's overlying a rib, and you would say, you know, you should do some obliques. Bring this person back, do obliques. You can answer with radiography. Some people would proceed directly to CT, but I can show you that on a tomosynthesis exam, you would deliver very close to the same dose as a chest X-ray, and that question would be answered immediately at the reading of that CT. It's obvious that this is actually a rib lesion. If you look at the images on the right, I'm showing you that it's a healed rib fracture on CT. Okay, let me show you another example. This is another example of a rib lesion. This was a sclerotic lesion in a posterior rib, and you can see again in the anterior ribs. And then you can see again on the radiograph, you see this opacity. Not sure where it's located. You'd have to bring them back for something. Okay. On the CT, you can see it's a sclerotic lesion, but the tomosynthesis image is in the center. It's obvious this is a rib lesion. This is not a pulmonary lesion. Okay. So overall, with respect to nodule detection, in the study that I specifically mentioned and many others that reached a very similar conclusion, tomosynthesis diagnoses about twice as many nodules as chest X-ray, right? And it detects about a third of the nodules that you see on CT, right? It is better at preventing false positives, right? And I'm going to talk a little bit later about how this plays into utilization, right? Another thing is that tomosynthesis is as accurate as CT at measuring nodule size, which is something that can be useful if you're following nodules to look for size change. Okay, so it's good at detecting nodules. It doesn't just have implications for lung cancer. There are things like metastasis this has implications for, and people have specifically looked at this, and you may wonder, why, what's the point? I mean, nodule is a nodule, but that's not true. You really have to examine a clinical population to answer the question, because primary lung cancer and metastasis, yes, they're both nodules, but it kind of ends there. There are a lot of things that are different that would affect how well these things would be detected. For example, lung cancers tend to be apically predominant. Metastases tend to be basilar predominant. The composition of lung cancers are a mixture of solid most of the time, occasionally ground glass. Metastases are almost always solid. And if they're going to be ground glass, you generally know they're going to be ground glass based on the histology of your tumor. In terms of growth characteristics, they're well defined for primary lung cancers. And for Mets, the growth characteristics can depend on a lot of things. You may have an idea of how things would respond based on chemotherapy, histology, type of tumor. All these things play into how well do you actually make the correct diagnosis with each imaging modality. The imaging settings can also be different. With primary lung cancer, it would be an incidental pickup. Someone's getting a scan for cough, and you find a nodule. Your pretest probability is low, and so that affects everything. But with metastasis, you're monitoring. You know this person has cancer and has a reasonable high pretest probability for having some sort of recurrence. And that also affects where you are on your ROC curve. Okay, thank you. Sorry for the brief pause. We had some technical difficulties, but we'll get going again. All right, here we go. Where was I? Slide 36. Okay, so I'm not sure where things stopped, but I'll just pick up on this slide. So people look specifically at metastasis and whether we can see metastasis with tomosynthesis, because they have a different distribution, different composition, all that. And the specific clinical question that this publication asked was, can we find non-pulmonary metastasis as well on tomosynthesis as well as we can on CT? And they looked at 142 patients. They all had colorectal cancer. They did all three modalities. CT served as the gold standard, and tomosynthesis found 93% of malignant pulmonary nodules. It found 83% of all nodules, which is interesting because you have to always ask that question, what is your true positive rate? Okay, and malignant pulmonary nodules are more likely to be larger and are also more likely to be easily seen. Okay, and again, they repeated this finding that nodules greater than 4 millimeters are much better seen. So we talked a lot about nodules. Another big finding that we have in radiology, particularly chest radiology, is ground glass. Ground glass is essentially your non-solid pulmonary nodule and a lot of other things. The differential for ground glass is very large, and the problem is ground glass is very difficult to see on radiography. Patients come into the ED, they have an abnormality that is manifested as ground glass, they get a chest x-ray, you see nothing. So to illustrate that point, look at this patient on the left with the patchy ground glass. I'm going to show you a chest radiograph of that exact same patient. It looks normal. Okay? Now, ground glass is present in this patient, and I've listed the possible diagnoses based on the finding of ground glass. Now, depending on the pattern of ground glass, I would narrow this differential, but essentially looking for ground glass is a challenge. And the question is, can tomosynthesis see ground glass better than radiography? That would be very, very important. So let me show you an image here. This is a case in a patient who had a pneumonia. The chest radiograph on the right looks normal. The one on the left actually shows an abnormality near the right hilum. In fact, you can see an air bronchogram. If you look at the CT, this patient had some solid nodule, but they also had a lot of ground glass that you're seeing there on the tomosynthesis image. In fact, I think you even see the ground glass in the left lung on the tomosynthesis image. Okay, so people have looked at this specifically. In one paper, and I want to talk about this one in detail, they asked the question, can tomo detect ground glass better than chest x-ray? And can it detect as well as CT? And a very similar study design to the other papers. And what they found was that, their conclusion was that chest x-ray and tomosynthesis have similar performance. In other words, not very good at detecting ground glass. But this is the point I want to make. All right, I have no doubt that CT is probably superior to tomosynthesis for detecting ground glass. It is far superior to chest x-ray, chest radiography. But in this study, the ground glass opacities that they put in the patient were 5 millimeters or less. So those are sizes that we know tomo has difficulty detecting, number one. And number two, they're not really clinically relevant ground glass sizes. If you look at the possibilities of ground glass, and this is in my experience, things that are generally much, much larger than 5 millimeters, is everything. The only thing that often will be less than 5 millimeters is an adenocarcinoma in situ. So that's one very small slice of the possible differentials. All infections will be much larger than 5 millimeters, will be similar to the cases that I just showed you. So people may mention this finding when talking about tomosynthesis and ground glass, but I think they're taking the findings too far. And you have to think about, what is the ground glass that you are looking for? If you're looking for 5 millimeter ground glass, yes, I wouldn't use tomosynthesis. But if you're looking for viral infection, pulmonary hemorrhage, organizing pneumonia, anything like that, it's unclear, and it may in fact be very helpful. Okay. All right. Let me show you just some other areas where tomosynthesis, can have some findings in the hilum, which is the mediastinum and hilum, which is a tough place for radiography. You do get an improvement in contrast resolution with tomo compared to radiography. The radiograph on the left, very difficult to appreciate that there are actually calcified nodes present. There's the CT on the right that shows them, and the tomosynthesis image in the center clearly shows them as well. I'm going to do a thick slab CT overlay to show you what I'm looking at. I'm going to zoom up those areas to show you the actual calcifications. Okay, Let's talk about utilization. I mentioned a lot of times that there are things you can see on tomo that you wouldn't see on radiography. And we know that people often get radiography as a first-line treatment, and then they end up getting a CT. So what if you actually either did chest radiographs on people, instead of doing radiographs on people and then sending them to CT based on a questionable radiograph, instead you did the radiograph, then did tomo and decided, or just started out with tomo and decided what would happen to your utilization. And the thought is that you may have a lot of patients who you determine don't need to go for CT because the findings are not as inconclusive. So people have actually looked at this. The question was, can tomosynthesis reduce CT utilization as a first-line imaging modality compared to chest X-ray? They looked at 340 patients who had suspected pulmonary abnormalities on a chest X-ray who were determined to require a CT because of that suspected abnormality. Right? Those patients were imaged with tomo. They had people look at the study and then decide, do we really think this patient needs to go to a CT now that we've seen the tomo? And the answer was that in only 24% of patients did they still want to send them to CT. In other words, tomo answered the question in 76% of the patients. Either it was nothing, or it was actually something, and tomo was sufficient, and they could stop there. That is a very dramatic drop in utilization, which frees up a resource, prevents a hospital from having to buy another CT scanner, decreases cost, reduces radiation. And I think that's a very powerful finding. Okay, so that's an evidence-based look at implementation. What is my personal view of how implementation of tomosynthesis works? And I do want to preface this by saying I don't necessarily have I don't have any specific evidence behind this, but it's basically just my understanding of the evidence that is present in my own experience and what seems logical. I think tomosynthesis would make a lot of sense in remote locations that cannot have a CT for whatever reason, but have chest radiography. It may make sense for those locations to have tomosynthesis so that you have cross-sectional imaging on site for those patients. Right? Another is environments where patients may not have another encounter with healthcare. This comes back to the picking of the incidental lesion. So healthy outpatients. Someone comes through, they have a problem, you take a chest radiograph, it's normal. That person will walk out of your office and not come back for years. So this is an opportunity to make sure you don't miss anything. All right. So healthy outpatients. Emergency departments is another one of these scenarios. Someone who comes through, they may not have another encounter with healthcare for a long time. Radiation is not an issue for these patients, and the radiation from tomo is just a small increment more. You should really do the best you can to make sure you don't miss anything, either a diagnosis related to their complaint or any other incidental finding. Right? Any situations where you have a clinical don't miss lesion that is currently investigated with chest X-ray. For example, looking for metastasis. People have these radiographs that do surveillance for metastasis year after year. Those patients may be better served with tomosynthesis. CT would be too much radiation. Tomosynthesis is not that much more, but your sensitivity is so much higher. Right? Any patient that will receive repeated imaging, and when I talk about this, I think say patients with cystic fibrosis, who are going to get chest X-rays and CTs for their whole life, they're going to live for decades, they may be better served by tomo. And then, of course, pediatric patients where radiation really is a concern, where if they have an unclear chest X-ray, instead of sending them to CT, you do a tomo first. Okay? All right. So, barriers to implementation. Tomosynthesis is a new modality. Physicians don't perform it, in my opinion, many times when they do have it, because they feel uncomfortable reading it. Right? And I think the way around that is just physician education. And maybe start by doing things in parallel, doing chest X-rays with tomo, so that they that they have the other modality there to sort of confirm their findings and help them with their comfort level. Okay, so let me just show you some cases and then we'll be done. These are just some interesting cases. This was a patient who had, who there was a concern that he had aspirated something. We went ahead and did a radiograph, and we saw something overlying his right lower lobe airway. And in the tomosynthesis scan, you notice that you can see this entire foreign body in his airway here. This was actually one of these devices used for vocalization that he had aspirated. This is a case of a pleural effusion, just to show you how well the meniscus is seen on tomo. I mean, look at the detail of those vessels there, and you can actually just see the fluid level located. It's a very, very small pleural effusion. On the CT, there's a little bit of blunting of the costophrenic angle, but you can imagine where tomo would be very helpful for seeing these small effusions. Okay. This is a patient with pulmonary fibrosis, and this is what I was talking about. Look at the amount of detail on the tomo image in the center. Compare that to the CT on the left. I mean, you can see that the patient has fibrosis and lung disease, but it really does look like a low-resolution version of the tomo image. And I'm not even showing you the full-resolution tomo image. So I think for pulmonary fibrosis, and maybe even seeing how people progress with pulmonary fibrosis, it would be very, very useful. Okay. This is a patient with cystic fibrosis, and I want to show you the level of detail that you get from tomo. A lot of these patients just get imaged with radiograph because there are concerns about radiation dose in these patients. So on the left is the radiograph of the person with cystic fibrosis, and on the right you have the tomo. Of course, I'm only showing you one plane. I'm going to actually show you a zoomed up area so I can really show you the kind of detail that you get. Look at this. You actually can see individual airways. You can tell if there's airway thickening. You can really appreciate the bronchiectasis that's hiding behind here, and maybe even see new areas of consolidation. I think it's very, very helpful in these types of diseases. This is another image from a patient with cystic fibrosis. I'm going to show you detail from the right upper lung. And again, look at the difference in the detail. I mean, you can see there's abnormality here, but you can actually characterize all the different airways and structures with the tomo exam. I just think it's impressive. Okay. Just these things that we see every day on CT, on radiography, that are just much better seen on tomo. Here's an example of somebody just with aortic calcifications. You can see how well you can see that anatomy on tomo. It almost looks like a CT image. On the radiography, it's a little more difficult to see. And I actually think tomo would be fantastic for looking at device placement, where maybe catheters are in patients with a lot of hardware, things where it's difficult to visualize structures because of overlapping anatomy. Okay, so we've talked about a lot of things today. In conclusion, okay, I think that tomosynthesis is a fantastic modality, and I honestly feel that way, and that's why I was very, very excited and happy to give this talk, because I think that there's a lot it can do for patients. I think it is not a financial stress for a lot of institutions to have this modality, and there's really a lot of effective patient care that can be delivered, and I really want to help people lower that barrier to making that happen. So I think there are modality strengths, and one of them is high resolution, absolutely. The fact that the radiation is only about double what it is in chest X-ray, the fact that you can have tomosynthesis in sites that are designed to have a chest X-ray, whereas you wouldn't be able to put something like a CT scanner there. So you can actually increase availability of that resource to patients who might be in environments where they can't get it, like remote locations. Right? It also can be used for the entire body, so you're not just sticking some instrument that's just good for chest. Okay, you can image all parts of the body, and I think the musculoskeletal applications are also very promising. In terms of practical implementation, again, as I said, I think locations without CT availability that need some kind of cross-sectional imaging is very useful. I think populations like outpatient and ED patients, again, would be very useful. These are patients who are only going to encounter healthcare once, and then they may not come back for a long time. So you want to use capitalize on that opportunity as much as possible to make sure that they don't have any, that you don't miss anything. Okay, and again, in situations where you're looking for don't miss lesions that are currently investigated with chest X-ray because of dose concerns or other concerns. Okay, so that is the end of my talk. Thank you for listening. I really appreciate the time you've given me. I'm going to take a look at some questions now and see if anyone has some questions. Okay. All right, just a moment. I have one question here. You have to be patient with me as I figure out how to pull this up. Okay, one question is, what is the learning curve like for reading tomo exams? Okay, I think that's actually a very good question because, you know, some people automatically think, well, you should just be able to read this thing. I mean, you're a chest radiologist, you look at chest X-rays and CTs, it's not that much of a stretch, but it is a new modality. And in terms of answering that question, what is the learning curve like? I can tell you that from personal experience of looking at these exams, I think it's obviously much faster because we do, because you know we are radiologists and we look at the chest. We're used to looking at chest radiographs. I think that if I were going to say a number of exams, I don't think I could say that. I do think you do rapidly become comfortable, although having tomosynthesis in patients who have had CTs in the beginning really helps a lot because you are establishing your baseline and getting used to what you're looking at and you're using that CT as a reference. That is very, very helpful. So doing tomo in parallel with another modality in the beginning, I think is very helpful for clinicians to learn the modality. There is some data actually in breast tomography that shows how people learn over time. And I think there was one study that showed after 1 year of using the modality, basically the sensitivity and specificity oscillated up and down, but it started to plateau about 9 months into it. Now that is in the setting of breast. It's a targeted clinical question, high volume. So I don't know how to apply that to chest radiography. But I think if I could give one tip, it would be I think it's good to start out with doing tomo in addition to your routine modality in the beginning as people feel comfortable. Okay. Let me see. We have time for one more question. Okay, so let me see. I've got a couple questions here. All right. Okay. There's a question here. What kind of training is available for tomosynthesis? That is also a good question, considering the prior question. I think there are a lot of publications. There's a radiographics article, multiple reviews. That's really where you can get exposed to instruction on how to read tomo. I'm not familiar with any textbooks on tomo, and there are webinars like this. So I think this is an area that people have to actively work on to provide educational resources for imagers to learn. So that is definitely a need. But currently, there are, again, webinars like this. There are, and there are a lot of articles out there, review articles. And there's a radiographics article, which I was involved with, which obviously I always like to endorse. So there are some resources. Okay. I think that's all the time we have for questions because we are at our 1 hour mark. Again, thank you all for taking the time to listen, and good luck implementing the modality if you choose to do so. Thank you.